Good afternoon, everybody, and a very warm welcome to the first of this series on demystifying medicine. So what I will be doing is speaking for about 15 minutes about the clinical condition, what patients experience, what they feel, how we diagnose it, and a few words about the treatment and why we choose particular treatments over another treatment. We're very fortunate to have a patient with us today. Jamie is right here, sitting in the front. And after my formal presentation, Jamie and I will interact a little bit to talk a bit about his asthma, how it was diagnosed, what symptoms he had, his treatment, and so forth. And then Mark Inman, my colleague and good friend, who's a basic researcher in asthma, is going to speak for 15 minutes or so about studies in asthma, mechanisms of the disease, and what still needs to be known about this very common condition. And then we'll open up again for questions and comments and so forth. So you get lots of chance to ask questions to make sure that every issue you've ever wanted to know about asthma is answered in the next hour and a half. So I'm going to begin by talking about the clinical condition. What is asthma? And it's a disease that has a series of characteristic symptoms, which the most prominent of which is shortness of breath, or in medical parlance, dyspnea. Dyspnea is a Greek term meaning abnormal breathing or difficult breathing. And that is by far and away the commonest symptom that a patient with asthma experiences. Wheezing is a very common presenting symptom, cough, and chest tightness. They would be the four cardinal, common, frequent symptoms that a patient would come to the clinic and say, I have these symptoms, what is the problem? Now, importantly, none of these symptoms are specific for asthma. So dyspnea, or shortness of breath, occurs in a lot of different conditions. COPD, or chronic obstructive pulmonary disease, heart failure, even patients with very severe anemia, for any reason, become dyspneic because the oxygen carrying capacity of the blood is reduced. Many lung diseases. So dyspnea by itself, not characteristic. Wheezing, not characteristic, found in a lot of different conditions. Cough, all of you have had cough at some point in time. Absolutely not characteristic for asthma. And even chest tightness, that sensation I'm going to allow you to experience in just a moment, is not characteristic of asthma, found in a lot of different conditions. Now, I'm going to do a little trick. My colleagues who are in the audience have seen this before, but for those of you who haven't, I'm going to let you experience a little bit what chest tightness is like. But also I want you to think, and I want everybody to take a straw. Now when you have the straw, you can imagine that this is the airways inside your lungs. Because asthma is a disease of airways. And I'm going to be rather careful not to talk too much about its mechanisms, because that's what Mark will talk about. But what I will say is that the main problem with asthma is that the airways are narrowed or obstructed. So if you imagine that this is your airway, and I want you to put the straw in your mouth, and for about 10 or 15 seconds, breathe in and out. And I want you to think about one thing. You're going to feel discomfort. That I promise you. I hope nobody faints and starts to hyperventilate. That would completely spoil my day. So I want you to take a few deep breaths in and out, and I want you to think about what is providing the most discomfort. Is it breathing in, or is it breathing out? Put the straw in your mouth and start breathing for about 15 seconds, in and out. Does anybody feel normal doing that? No. All right. So nobody feels normal. That's the discomfort sometimes called chest tightness or discomfort in the chest associated with asthma. But is the problem, I want a show of hands here, you don't have to commit to this, for those of you who think the problem is breathing in is the more difficult, put your hand up. For those who feel it's breathing out is the more problematic. Right, so that's the vast majority. And that is in fact the problem. And that's a very characteristic question that I ask patients who present with asthma, is the difficulty getting air in or is it getting air out? And those who have asthma will always say, when I'm really sick, it's problems getting air out of the lungs. I won't talk about the pulmonary mechanics associated with that. Maybe you can ask Mark in the question period. He's good at all this stuff. But that is in fact the issue, that the lungs become hyperinflated, gas gets trapped, and it's much more difficult getting air out of the lungs. Now, to give you an example of why this is relevant, last Thursday, I have a clinic on a Thursday, I saw a young lady who had been told she had asthma when she was age 13. She's now 27, 14 years of diagnosis. She'd been on medications on and off, but she came to see me because she told her family doctor, the asthma medications don't work. When I'm short of breath, I take the puffer, we'll talk about that in a few minutes, doesn't help me. So she arrived in the clinic, and when I asked that question, I knew what the problem was. I said, is the problem when you're sick getting the air into your lung or getting the air out of your lungs? It's always filling my lungs. I just cannot fill those lungs up. I can't, the sensation is I just haven't got enough air in. That's not asthma. So with that question alone, I wasn't certain, but I had an intimation this lady didn't have asthma. And we did a test. I'll show you in a moment what that was. It was completely normal. And so I could tell her confidently she didn't have asthma. She had something else, and we'll talk about that in a few minutes, but it wasn't asthma. So it's a useful question to ask. So how do we make the diagnosis and be confident about it? And this is perhaps the single most important slide I'll show you today. Because as a physician, I have a responsibility with the patient of getting this right. We're giving somebody a diagnosis that's likely lifelong and may need treatment for much of that time. And if the diagnosis is not right, you are enforcing treatment on a patient or somebody who's coming to see you who doesn't have that condition. And so to make the diagnosis, we have to have two things. We need to have the characteristic symptoms that I've described to you, but also, really importantly, we have to have objective evidence of variable airflow obstruction. Now, what is that? Well, asthma, characteristically, is a variable disease. And what I mean by that is that some occasions the patient will be perfectly well, absolutely normal, and on other occasions very ill. And that variability is an important part of defining asthma. And that variability can be measured by looking at evidence for airflow obstruction using one of these three methods of measuring this variability from day to day or even occasionally from hour to hour in patients. Spirometry, peak expired flows, or something called airway hyperresponsiveness. And I'm going to talk briefly about each of these so you know how we use these in order to establish confidently that the patient does indeed have a diagnosis of asthma. Spirometry is measuring the volume of air that can be exhaled out of the lung in a given period of time. And when I was a young lad here at McMaster, this is how we did it. This is called a water spirometer. That's P.J. Sabaro, who was a postdoc in the lab at the time. She posed for this picture. And this device was extraordinarily robust way of measuring lung function, or spirometry particularly. Nowadays, we use electronic spirometers, mostly computer-based spirometers. And what these are measuring is this. This is a slide that shows time in seconds and volume on the y-axis in liters. So when Jim Kane, who's sitting in the far corner over there, gets somebody in and is measuring spirometry. We ask them to take a big breath in, all the way up to total lung capacity, which is as full of breath as you can get, and then blow as hard as possible into one of these spirometers I've shown you. And the amount of volume that comes out of the lung is measured over time. So in this instance, this is a measurement before a patient is treated with a medication for asthma, and that's about 10 minutes after the medication. And that's the volume blown out, and we measure this, we actually quantify it, by looking at something we called the forced expired volume in the first second. So the first second of that fast, hard blow, that is the volume that this patient blew out. That's about 1.7 liters of air was blown out in that first second. We then treated the patient, a couple of puffs of this medication that works by opening the airways, this obstructed airway that I've shown you a moment ago, opening it up, and they did exactly the same maneuver 10 minutes later, and that's the volume that was blown out. Let's say 2.5 liters. Now that test shows the patient has variable airflow obstruction. It's obstructed airway, we gave a treatment, it improved. That's the definition of variable airflow obstruction. And this test, together with the symptoms, would be sufficient to make a diagnosis of asthma. Sometimes this testing isn't easily available, and we rely, although much less now than in previous years, because these machines are becoming much more widely available, much cheaper, easier to obtain. But we have in the past, and to some extent nowadays, on a much cheaper version. This is called a peak flow meter. That's a picture of a peak flow meter. I should have brought one with me, but it's about as long as the straw, maybe a little bit longer. It costs, what does a peak flow meter cost these days, Myrna? 50 bucks? Yeah, maybe even less than that. And it is also measuring the flow in a very rapid breath. And so you put this into your mouth, full breath in, and then blow hard, like that, and it measures the amount of air that can be blown out. And again, if the airway is obstructed, that volume will be reduced, and if it gets better, it'll be improved. And so the way that this is used is by patients is to ask the patient to make measurements in the morning and at nighttime, because in all of us, everybody in this room has some component of variable airflow obstruction, very small. Your flow rates are different in the morning and in the evening. You have to use pretty sensitive methods to measure that, but in all of us there is a diurnal variation, a variation through the day in the flow rates that you can measure. But it started for asthma, and you can see that even in this period of a week, it varied between 300 and a little over almost 700. And so the way this variability is calculated is by putting the lowest value, 310, over the highest value, 700. So that is the variability is 44%, or the lowest versus compared to the highest value. This patient is now treated with a treatment for asthma. We'll talk about this in a few minutes. And 3 weeks later, there's a little less variability. 6 and 7 weeks later, it's very much less. And so now, the peak flows at the worst are 620, and at the best 720. So it's 86% of the lowest compared to the highest value. So this documents variable airflow obstruction, but also documents the benefit of the treatment in this patient. And again, I'm going to come back to the treatment in just a couple of minutes. The final thing we can do to document asthma is measure this entity called airway hyperresponsiveness. Now, why would we do that? And what is it? Well, the reason we would do it is that because asthma is variable, very often you sit a patient you sit a patient down in the chair in the office, and they'll tell you their history, And when you measure spirometry on the day they're seen, or peak flows on the day they're seen, it's normal. And there's no variability after a bronchodilator. If you measured it the week before, or maybe the week after, it might not be. But on the day they're being evaluated, it's normal. So how else can we prove that this patient does indeed have this variability in airflow obstruction, or another term I like to use to patients, I show them my hand, is your airways are twitchy. They tend to constrict and relax much more than a normal person. And the way we can measure that is by having them come to the laboratory, and we give them increasing concentrations of an agonist, a mediator that we know will constrict the airways, and we measure the FEV1, just as I showed you a few minutes ago. And if we got everybody in this room into the lab, most of you would have some constriction of the airway if we gave a high enough concentration of the agonist. But the difference in asthmatics is that they need a much lower concentration of the agonist to cause that constriction, and importantly, they constrict much more than a normal person. Normal individuals, non-asthmatics, have this plateau effect. So at a certain point, they stop constricting. Asthmatics lose that. And that's part of the reason asthma is so potentially so dangerous, because the airways can obstruct virtually completely in some asthmatic subjects. And we measure this by the provocative concentration of the agonist causing a 20% change in FEV1, or the PC20. And I'm sure Mark will be talking more about these measurements in his presentation, because a lot of the work we do, understanding mechanisms, is to understand why this is present in asthmatic airways. This is very non-responsive. There we are. The final thing that we can do to measure this twitchiness of the airways is an exercise challenge test. Now, why would we bother doing that? Well, the reason is that exercise is a very common stimulus to cause constriction in asthmatics. And very often, milder asthmatics will come and say, I'm out running, particularly on a very cold or a very hot, humid day, and I start getting tightness in the chest, and I wheeze and cough. Do I have asthma? Well, you can do the other testing, and that's perfectly acceptable, but you might decide to mimic the event that led to that in the patient by doing an exercise challenge. And so we would do this in a laboratory setting, exercise the patient usually for 8 minutes on a treadmill or on a bicycle ergometer, measure lung function, and that's what happens if you have asthma. The lung function declines over about 15 minutes and then gradually recovers back to baseline in an hour or so. This is exercise-induced bronchoconstriction. And again, it's something we have to take care of in asthmatics, because we want our asthmatics to be exercising just like everybody else does, if they want to. And in fact, if you treat asthma properly, many asthmatics compete at a very high level in athletics and other sporting events. How common is asthma? How frequently do we see it? Well, this is a slide taken from a very interesting study, the most recent iteration published 2006, called the ISAC study, that did exactly the same testing in all of these countries to evaluate the prevalence, or how common asthma is in children, in a wide variety of different countries. And if you look towards the top, if I can get, there we are, Canada is 5th from the top, and the prevalence of asthma in children in Canada, at least in these centers where it was evaluated, was at least 20% of all children. This is up to age 14 years. The only countries higher were Ireland, where I'm from originally, Australia, New Zealand, and the UK, where the prevalence was as high as even over 30% of children with the diagnosis of asthma and treated for asthma. Another important point about this is that if you look down the list, there is a very wide range of prevalence. In some countries, like China or Russia, Mexico, for example, less than 10%. And in countries like Canada, over 20%. And in fact, the evidence is that the more developed countries are, the higher the prevalence of not only asthma, but all allergic diseases. And that's a very interesting research area that we don't yet fully understand. Lots of hypotheses why that's the case, but I have to say we really don't fully understand why there is this wide range of responses. Another important fact is that as countries develop economically, the prevalence of asthma goes up. And when children move from a rural environment in countries like Zimbabwe, where this has been studied, to an urban environment, the prevalence of asthma goes from close to 0 to right to the level of the rest of the country in that urban environment. So these are important clues we haven't yet figured out. It's very slow. Last couple of slides on what we do to treat this problem. Now, in the past 5 or 6 years, we have changed our view about treatment. And I'm not going to go into all the complexities of this other than to say we want patients with asthma to be normal. Normal. Normal in the way they function, the way they get through their day, not missing school, not missing work, exercising as they should. And we call that overall asthma control. And this is by making sure they have current control, no symptoms, don't require any rescue medication, normal activity and normal lung function, but also making sure that they are not at risk of having particularly severe asthma exacerbations or flare-ups of asthma. And this is the time when patients are at most risk of a really bad event with asthma. And still, unfortunately, in Canada, there are over 300 deaths, that's almost one a day, from asthma, even in a country where asthma, I think, is generally treated very well. Exacerbations are particularly problematic, and I want to show this slide because this is data from Hamilton. Neil Johnson and Malcolm Sears reported this, and this is not an electrocardiograph. For those of you who might be in the biomedical science business, you might think this is a P wave, QRS complex, a T wave. That's not that. This is the occurrence of severe asthma exacerbations in Ontario in every year between 1990 and 2000. And as you see, in virtually every year there's a peak. And the area under this curve accounts for about 60% of all asthmatics, children, asthmatics seen in an emergency room or hospitalized. And it occurs in a 2-week period in the year. And that is the 2nd and 3rd week of September. Now, what happens to children in September? That's different from the rest of the year. Well, in Canada, they have the summer vacation, and in September, usually the 1st week, they go back to school. And it turns out, and Malcolm and Neil proved this very nicely, this exacerbation rate is caused by exposure to respiratory viruses in the school. And these viruses are shared, and then the kids bring them home, and their siblings get them. Everybody gets a respiratory virus during that, or most people, during that couple of week period. These are mainly rhinovirus, the common cold virus, and Neil and Malcolm and other colleagues have demonstrated very convincingly that this is the cause of this peak, and in fact, viral respiratory infections are the cause of probably 70 to 80% of all severe asthma exacerbations. So you have to have asthma, and you have to have the virus. And if you have both of those things, you're at risk of having a very severe flare-up of asthma. So how do we make sure this doesn't happen? Well, this is the Canadian guidelines on asthma treatment. I'm not going to go through this because, to be honest, I find this slide a little busy and a little difficult to explain in a minute or less. Rather, I'm going to go to this slide, which is the same information, but shown in a different way. And this is a group called GINA, the Global Initiative on Asthma, that I've worked with for a number of years. And this shows you the treatment steps for managing asthma. And what it says is that Everybody who has asthma should have access to a reliever medication. This is a puffer, an inhaler, that gives you this rapid relief, as I showed you on the spirometry slide, where they get benefit in a few minutes, 5 to 10 minutes. And then anybody with regular symptoms should be treated with an inhaled corticosteroid. This is a medication that reduces the inflammation of asthma. Mark will talk to this. It improves asthma markedly in patients, as you'll see in just a few minutes. Other medications sometimes are needed, sometimes more than one, to try and get this overall asthma control. But with the medications we have, and we've been using now for more than 40 years to treat asthma, the great majority of asthmatics can be normal. Almost all the time. Normal almost all the time, including exercising, doing everything that anybody else who doesn't have asthma does. And that is our objective in managing these patients. And we are very fortunate that we have ways of getting medication into the lung in very small doses that is extremely effective. Topical treatment into the lung to treat a lung disease, an airway disease. And these are inhalers of various types. Some are metered dose inhalers, or what the patients like to call their puffer. Puff it and it squirts out. And some of these are dry powder inhaler. These have powder, a very finely ground powder that you inhale out of the device like this. And this is an important device, an aerochamber, I'm very proud to say, developed here in Hamilton by Myrna Dolovich, who's sitting right over there, and Mike Newhouse a number of years ago. And this should be used in every patient who's using a steroid puffer. You put it in one end and you breathe out the other end, and the bits of the medication, the parts of the medication you don't need, which stick in your mouth, get stuck here, and the bits you do need into the lung get down into the lung. So that is a very brief summary of the disease, how frequent it is, how we diagnose it, and a little bit about the treatment. Now, I'm going to stop. Oh my goodness, I've talked much too long. I'm going to ask Jamie to come up here for a few minutes. He and I are going to interact about his asthma, and then I'm going to stop and let you guys ask questions or challenge me about issues or whatever you think is appropriate. So Jamie, come on up here. So Jamie kindly agreed to join us. He has had asthma since he was a young lad. And maybe I'll just ask you to tell us a little bit about the symptoms you had then, Jamie, and what you were experiencing before the diagnosis was made.
Well, I don't actually remember it myself. I was only 2 at the time. I had a number of episodes where I had to go to the emergency room because of shortness of breath. I couldn't breathe at night. And I received treatment in the hospital there. And from that point onwards, I was on medication for my asthma, a once-a-day puffer kind of thing.
And as you grew up and started going to school and functioning at school and playing sports and so on, did your asthma impact any of that?
I've always been very bad with cold weather exercising. I can remember a number of incidents in primary school when I became wheezy at recess in the winter time, and I'd be running around and it's so cold outside. Also, cats have always been a problem. If I'm at a friend's house who's got cats, I'll always get a reaction quite soon there.
And what about once the diagnosis was made and you started on effective treatment? Did you notice any difference at that time?
Yes, it did get much better. But like I said, cats and cold have always been triggers no matter if I'm on daily medication or not.
Have you had any really severe exacerbation that you remember? I know you talked about the ones when you were a very young child.
I have not.
You've not been in the hospital emergency room or anything like that?
No.
Okay, good. That's good. Good news. Do you have problems with your medications?
Taking them, or what do you mean by that?
Any. I'm putting the very broadly based question.
No. It's very easy.
Very easy, all right. Do you have problems remembering to take them?
Yes.
Ah. Very good. Because, in fact, that is a huge issue in managing asthma. The medications are effective. Patients feel very much better. And then suddenly either they elect to, or they choose to, or they forget to take the medication. And sometimes they say, well, I'm feeling bad. I don't want to be on this stuff, so I'll stop it. And that is, I would say, frankly, the majority of asthmatics. And then after a couple of months, things begin to get worse, and then they come back and they have to go back on medication. Has that ever happened in your experience?
No.
No. Good. Very good. All right. Excellent. Now I'm going to show you one more slide as Jamie is. No, you stay right there, because this is actually a slide about Jamie. Let me go back. There's Jamie. We figure maybe age 10 years old.
Yep.
And you can't see it, but that is a hedgehog. So Jamie was not allergic to hedgehogs. So that's, I assume, your pet at the time, right? And these are Jamie's peak flow meters. Remember I showed you the peak flow? These are his peak flow readings. And this is when he was started on this dose of inhaled steroids. And you can see if you follow this, the trend is to increase. The dose was reduced, and that's very important. Once we get good control, we try to minimize the amount of medication needed to keep the patient well. So he went to a lower dose, and you can see that the peak flow started to drift down. So he was put back on this higher dose, went up again, then he was exposed to a cat, and as he told you, he's very allergic to cats, so he had this little flare-up, and he also developed that's not a urinary tract, it's a upper respiratory infection, the virus I talked about. And again, had a flare-up when he was exposed to a virus. And guess what? September, right? So that's part of the September epidemic that we see in children who have asthma. So this is a lovely demonstration of Jamie as a young fellow, looking very optimistic. Look how tall he's grown despite all this inhaled medication, and he's been fit and well. He's functioning well. He's doing a master's now. You like to exercise, I guess, and doing all the things he should because of effective treatment of his asthma.
So I'm going to talk a little bit, probably Dr. O'Byrne alluded to the fact that I'm going to answer all the questions that he raised very vaguely, and that's not true. I won't answer any questions in specific detail, but I'll try and give you a bit of an overview about what we do know about asthma and how we're trying to find out the things that we don't know. And you guys can be the judge as to whether we're doing that. Translational research is kind of a new idea, or it's a new term, but I think it's always been around, which is a way to try and ensure that the research we basic scientists are doing is somehow related to clinical practice. So that is that we're generating relevant knowledge. This is often thought of as a sort of one-directional approach, that we should always make sure that the research we're doing is generating relevant stuff. That's not actually true. In order to make sure you're asking the right questions as a researcher, you need to look very carefully at what's going on in clinical practice and realize what the shortcomings are. So Dr. O'Byrne today told us a lot about some of the shortcomings in his practice of medicine, or practice of management of asthma. So as a researcher, you need to be aware of what these shortcomings are, so that you're going to be answering questions that are actually relevant. Otherwise, you can spend a lot of time contributing to what I call irrelevant knowledge. And some of us are exquisitely good at doing this. Even when we know a lot about what the shortcomings are, you can often find yourself contributing to this pile over here, which I think I've made a career out of doing that. That's not always bad, because any knowledge is actually helpful. So you can always say, this knowledge will increase our understanding of asthma. So you can definitely contribute knowledge that's increasing the understanding of asthma without necessarily directly impacting clinical practice. So don't be alarmed if your research is doing this. Years later, it may change. So what are the clinical shortcomings in asthma? So Dr. O'Byrne mentioned that often, despite his best intentions, patients will still have symptoms despite getting the best treatment. And Jamie mentioned that he will occasionally still have symptoms. So if that's happening too often, is there something we can do as researchers to try and address these symptoms that are breaking through despite best treatment? Dr. O'Byrne mentioned that most of the patients he sees have difficult to treat asthma. So these are patients who, when they're given the regular treatment, they still have serious problems with their disease. Is there anything that we as researchers can find to help these patients manage their asthma over and above what can be done with the regular treatment. Then I think perhaps the most important question is this, that right now we have a continued reliance on medication. And when Dr. Byrne asked Jamie whether he has any troubles with his asthma treatment, it was, yes, I forget to take it. So is there anything we can do to manage asthma so that we don't have to rely on continued medication? And this is actually looking towards a cure. Can we cure asthma so we can take Jamie, do something to him so that he no longer has to remember twice a day to take his asthma medication? So what I'm going to do in the remaining time is very conceptually talk about asthma. I'll talk about the underlying problem, which is bronchoconstriction. Then I'll give a conceptual overview of what we understand about what sort of things cause asthma and lead to the symptoms that the patients experience. And then I'll go back over that conceptual overview that I've given and talk about the different research approaches and how some of them might be helping our understanding of the disease. Okay, so the underlying problem in asthma is bronchoconstriction. Hopefully a lot of you don't do research in the lung. Hopefully a lot of you have come as this is a chance to learn about another disease, but most of you probably are well aware that the lung is important for gas exchange. So we breathe air in, it travels down the trachea, gets into the parenchyma of the lung where the alveoli are, and as it travels along these airways, if you magnify, you can see that in the distal airways, the air is still traveling along, and in the alveoli, it expands the alveoli, fills it with air, where the blood vessels can pick up oxygen and deliver carbon dioxide and take that oxygen to where it's needed in the body. So, as all of you were aware, we're acutely aware of when something happens to make it difficult to get air along these airways, and obviously that's important to us, because if we're not getting air down here to support gas exchange, we will all die. So if I take a section of an airway, I put a little section here, and look at an airway in cross-section, this is what you see. So the airway lumen, the part in the middle, which is where the air travels up and down, goes the full length of the lung, is something like 23 different branch points when you go from the trachea down to an alveoli. That airway is surrounded by a healthy epithelial barrier, which prevents things that we're breathing in from getting into our body. If you look around most of the airways, a little bit distal to the epithelium, you'll see a layer of smooth muscle. So all of your airways are surrounded by smooth muscle, down to a certain point. And within the space between them, there's a lot of support structures, like blood vessels to bring oxygen to these cells, there's nerves to innervate these cells, and you'll see the occasional inflammatory cell. So you guys have all of that, even if you don't have asthma. You've got airway smooth muscle, inflammatory cells. For the most part, these inflammatory cells probably don't do very much. They're surveying the airway. If something like a virus gets down there, they fight it as soon as they can. If that virus penetrates, it can actually start causing pathology, and you can get what's called a viral bronchitis. You can even get a bacterial bronchitis, and hopefully the immune system in you guys is able to fight that, and all you will experience is just some symptoms, some sore throat, maybe a productive cough. This layer of smooth muscle in your airways does pretty much nothing at all. So none of you, unless you have asthma, have likely experienced contraction of that smooth muscle. When that happens, that's what we call asthma. So when that happens in asthma, we'll talk about it in a few slides, in asthma you can have a lot more inflammatory cells that are fighting things that they see as a threat, or at least a perceived threat, and that can cause contraction of these smooth muscle cells. When that happens, what was once a big ring becomes a smaller ring, and the epithelial layer, which used to be nice and wide open, becomes compressed, and that airway becomes smaller. So in a sense, what's happened is you've gone from breathing through your nice big airways to breathing through a little drinking straw. And so every time Jamie experiences symptoms, that's likely what's happening. That smooth muscle is contracting, making the airway smaller. I think Dr. Byrne mentioned a little bit that another problem that can happen with asthma is you can get production of more mucus. You all have mucus lining your airways to keep it nice and moist. If you get an exacerbation of your asthma, you can actually get more mucus production. And you can see, especially if that happens in a smaller airway, you can end up with a very, very small hole to breathe through. And actually, although it doesn't happen very often, hopefully it doesn't happen to anybody that any of you ever know, you can actually die of asthma. And when that happens, it's usually as a result of really excessive amounts of mucus being produced in an already small airway that actually shuts the airway down. And usually when we look on autopsy, you will see that the airway lumen is completely occluded with mucus. So now I'm going to go over a very conceptual overview of asthma. I'm not going to tell you very much about any specific molecules. Rather, I'm going to tell you with cartoons what we think happens in asthma, and then I'll come back and tell you about some of the research that we're doing in asthma and ways that we think we can make advances. I decided not to show any data slides. In fact, I ended up deciding only to use one cartoon. So I'm going to use this cartoon. It's going to get a little bit bigger, but everything I talk about is going to be related to this conceptual cartoon that I built. So Dr. Byrne mentioned that a lot of people have asthma that is allergy-oriented, and Jamie mentioned that he's allergic to cats. There's a lot of sort of archetypal allergies that we know cause asthma. Cats is one of them. Another one, which is very common around here, is ragweed. And what we think happens with people who end up with allergy-driven asthma is that when they are first exposed to the pollen from the allergen, so you're all exposed to ragweed pollen on an annual basis, but some people, when they're first exposed to that pollen, the pollen is picked up by an allergen-presenting cell. So in this case, I've shown a dendritic cell, and that dendritic cell takes that allergen to the draining lymph node. You'll notice that I've started with number 3, so clearly there's things before this happens that we think are important in the development of asthma, and I'll come back to those. But we think asthma starts, or some asthma starts, when you're first exposed to an allergen. That allergen is taken to the draining lymph node where it's presented to a naive T cell. And I'm going to try not to talk too much about specific cells, but the T cell is one of the ones that we think is very important in asthma. For some reason, and we'll come back to that, when that allergen is presented to that T cell decides to differentiate in what's called a Th2 direction, and Dr. Byrne mentioned that. So this T cell in an individual who develops allergic asthma goes in a Th2 direction. When that happens, you end up with a proliferation of those T cells, which are very responsive to that allergen, and you end up with a proliferation of the associated B cell, which produces an antibody which we call IgE. So now then, this individual has armed T cells and IgE, which attaches to another cell called the mast cell, and goes back to the airway. So the airway now has an armed mast cell, a T cell, which is just sort of sitting there waiting to see that allergen again. And when that allergen is inhaled again, maybe the next year or 2 or 3 years later, those cells respond to that. I'm not going to talk about the mediators they produce, but they produce very characteristic mediators. Some of these mediators can actually cause narrowing of the airway, and they can lead to the production of other inflammatory cells. One of these is the eosinophil. So we think mediators or cells travel to the bone marrow, result in the production of the eosinophil, which comes back to the airway. So you now have a whole characteristic inflammatory response going on in the airway, and I'll come back in a couple slides to say what we think that does. Before I do that, I'll come back to why we're starting with number 3. So this is allergen that's causing asthma. And Dr. Byrne mentioned some people have allergic asthma, but others don't seem to have allergic asthma. It doesn't seem to be a known allergen that triggers their response. So while in some people you can find an allergen that A, initiates this process, and B, triggers inflammatory responses next time you see the allergen, others don't. They seem to have T cells that become armed despite not being allergic to an allergen. So you can get a T cell that is differentiated in a Th2 direction, triggering all of this pathology, but not being driven by an allergen. And we're absolutely not at all sure why that happens. So that's why I can't really go back beyond here to describe what's causing intrinsic asthma, because we don't know what's the starting trigger. Not all of you develop an allergy to ragweed, but you're all exposed to it. Most of you are exposed to it at a very young age. Not all of you develop asthma. So we know that there has to be underlying features in the individual or in his airway that makes him predisposed to this type of pathology taking place. Certainly there's a genetic component, so an underlying genes that may be responsible for asthma. And Dr. Byrne mentioned that if you look in the family history of somebody with asthma, you can usually find allergy somewhere as you go back. He also mentioned that it's more prevalent in different countries, which gives rise to the idea that there's something in the environment, whether it's local viruses, local bacteria, or other things that people are inhaling in those environments that also sets up the allergic or asthmatic response. But we know that there are features of environment and genetics which contribute to the development of the asthmatic allergic pathology. The other thing we know is that if you look in other tissues, like in skin, in the eyes, in the nose, you can get allergic inflammation, which is very similar to the characteristic allergic inflammation you see in asthma. But if you look in the airway of an asthmatic, you see a lot of different things too. You see what was referred to earlier as remodeling. So you can see a lot of structural changes in what was an otherwise healthy epithelium. The first thing you can notice is you can see a fibrotic layer beneath the epithelium. You can see a proliferation of cells called the goblet cells, which are very important in producing the mucus. And I think very importantly, you can see more airway smooth muscle. I haven't even drawn it for a healthy airway. But those are three of the big things you see in an asthmatic airway: fibrosis, destruction of the normal healthy epithelial barrier, and proliferation of airway smooth muscle cells. Then, if you look further into the asthmatic, you will see that the airway is hyperresponsive, and Dr. Byrne described that very well. So something about this inflammation and structural changes we think leads to the hyperresponsiveness of the airway. So it's more likely, the smooth muscle cells are more likely to contract. They're lined with many receptors to different agonists, so they can be made to contract with histamine, with acetylcholine. All of you have those receptors on your airway, and if I gave you high enough concentrations of histamine or acetylcholine, I could make your airway bronchoconstrict. But in an asthmatic, the airway is very hyperresponsive, and it can do that with a much lower concentration. We think that the combination of all of this, the inflammation, the mediators released from these cells, which can act on the airway smooth muscle, the greater amount of airway smooth muscle, and the hyperresponsiveness of the smooth muscle can lead to bronchoconstriction, the actual interacting of myosin and actin producing the contraction of the airway smooth muscle and narrowing the airway. So this is kind of a very general overview of our understanding of what asthma is. The current clinical scenario is that a patient will present to either their family doctor or possibly to Dr. Byrne, usually the family doctor first, and they will be at some stage of this sort of progression. The truth is that they are always in this stage. By the time a patient experiences bronchoconstriction, the remodeling process will already be present. There will be underlying inflammation, and when they come to the doctor, there's no sort of early point where they present and they'll progress to getting the disease. They present with full-blown asthma. The other thing that happens is that for the most part, patients, once they present with a certain sort of pathologic and clinical scenario, they generally don't progress. So Jamie doesn't need to worry that his asthma is going to get worse and worse and worse as he gets older. It will persist, and he'll need to keep taking the same drugs. But for the most part, a patient with mild asthma will continue to have mild asthma. The clinical armamentarium that Dr. Byrne has available to him was he mentioned was the inhaled steroids, which address this underlying inflammation. So if you give inhaled steroids to a patient with asthma, you can get rid of an awful lot of these inflammatory cells, particularly the eosinophil. The other drug that he has available is the beta-2 agonist he talked about, which will reverse any bronchoconstriction which happens to be present in the asthmatic. So, what else can we learn about the asthmatic? So what are the research approaches? So Dr. Byrne already alluded to one of them, which is epidemiological cohort analysis type approach. So who gets asthma? So there's a lot known about what it is in the environment that might predispose individuals to asthma. So he mentioned that individuals grow up in a rural area or on a farm are much less likely to develop asthma than individuals growing up in a city or in a very clean environment. There's certainly evidence that genes are associated with asthma, and there's gene finding studies that take place all the time, and certain genes have been found that are associated with asthma. One of them is a PGE2 receptor, which is prostaglandin E2 receptor. People who have a gene for a certain type of that receptor seem to be more likely to develop asthma. One thing that's absolutely clear, though, is that we are never going to find a single gene that's causing asthma. So we're finding a lot of genes that are associated with asthma, but no gene is ever going to be found that causes asthma. And what's increasingly happening is that we're finding that this research is very difficult because of a gene-environment interaction. So you may have a gene that makes you more likely to develop asthma, but unless you're in the right environment, which might mean a viral exposure or a bacterial exposure at the right age, that's actually not going to cause asthma in you. There's a huge study going on here. Dr. Byrne mentioned the child cohort study, looking at that. Clinical investigations. So we can take patients with asthma and look in their airway and find out what's going on. One very important one, which has happened here at McMaster at St. Joseph Hospital, done by Dr. Freddie Hargraves, who unfortunately passed away last summer. What he did was he looked in the patients of asthma. He could put a bronchoscope, or he could look at induced sputum. He'd get people to cough up into a cup, and he'd look at which cells were present in that cup after they coughed the cells up. What he found was that patients who had this cell, the eosinophil, were very responsive to inhaled steroids. So what he was able to do was to look at patients, define their asthma with this induced sputum technique, and give them the appropriate form of therapy. If they didn't have eosinophils, he knew he had to do something else other than just give them inhaled steroids. Other uses of clinical investigations is for testing mechanisms. So when we think a mechanism might be important in asthma, we can test it by looking in patients. And one of the things Dr. Byrne does is he takes actually reasonably healthy patients, gives them an exposure to a known allergen, and induces an asthmatic response, a little exacerbation of their disease. He can then use that model to test whether a specific intervention can help prevent that exacerbation. So this is a very useful way for testing which drugs might be effective. A lot of you are aware of animal modeling of asthma. It's important to know that no animals, possibly cats and maybe horses a little bit, get asthma. So there's no naturally occurring asthma in animals. What we can do, though, particularly with mice, is sort of trick them into getting a little bit of asthma. So if we give an allergen to a mouse under very, very specific conditions, we can reproduce this Th2 type sensitization and this Th2 inflammation. We've tried to look onwards in these models to see if they eventually develop some of these remodeling changes. And depending on who you get to look at the pathology, you could argue that they do, but they certainly don't get it to the same extent that humans do. And certainly they don't ever end up developing bronchoconstriction. So no animal models that I'm aware of develop spontaneous bronchoconstriction, but they develop a little bit of airway hyperresponsiveness. So these animals become very useful for studying different parts of the disease. But you have to be aware of the limitations of these models. One, I think, very appropriate use of these models is being done by Manel Jordana. What he's doing is looking at what early life events might predispose a mouse to becoming sensitized to an allergen. So what he's doing is playing around with delivery of viruses at different times in those mice, seeing whether that delivery predisposes a mouse to becoming allergic to an allergen. Another potential use, which isn't actually happening in asthma research, but is happening in other medical research, is when researchers find a gene of interest or a polymorphism of interest in a gene, can you take that polymorphism and insert it into a mouse and see whether that actually makes the allergic asthmatic model worse? I think that's going to be a very useful or very interesting use of mouse models, is inserting genes into the mice to see whether they better represent the diseases we see in humans. Clinical trials, so the final stage of the research, whichever research you're doing, mouse-based, epidemiological-based, or clinical-based investigative research, eventually, hopefully it will lead to a clinical trials where we can come back in with an inhaled drug or an oral drug and see whether we can prevent aspects of this disease. I'm not going to spend too long on that because I know we're running out of time. I think very importantly, any drug that we come up has to act differently than steroids because we know already that steroids are very effective at controlling this underlying inflammation. So a drug that's going to have a truly better effect in asthma is going to have to do something other than just simply reduce inflammation. So I mentioned I was going to talk about, is there any possible cures? So usually if you want to cure disease, you want to find some point very early on in the pathogenesis of the disease, intervene there, turn everything off, and see if you can cure the disease. If we give patients regular control inhaled steroids, you can control the inflammation, but the disease persists. Even though you're controlling the inflammation, the disease persists. We think that might be because even if you're controlling the inflammation, you can't get rid of this underlying pathology, the underlying sort of remodeling of the airway. One area of research which we think might be quite fruitful is what Dr. Byrne alluded to, which was immune reorientation. And there's a research here, Dr. Marc Larcher, who is taking small parts of antigens, giving them to the mice, and trying to shut down this Th2 type response to the antigen. When he does that in animals, it very effectively shuts down allergic inflammation. So it'd be interesting to see if you do that in humans, prevent this immune response to ongoing allergic exposure. Can he start shutting down the asthma that's out here? And the final thing I'm going to say is that very interestingly, one of the possible ways of curing asthma is not intervening very early, but actually going right out to the final effector organ, the airway smooth muscle. There's a researcher from Chicago called Julian Solway who said that if it wasn't for airway smooth muscle, the inflammation in asthma might not be a problem. What he meant by that is that all of this inflammation in asthma is causing a problem by resulting in the airway smooth muscle contracting. So if you could get rid of the airway smooth muscle and it wouldn't contract, would this underlying inflammation actually be a problem? And clinically, there is some evidence that that's true. You can look at patients with allergic rhinitis, so diseases in the nose. They still have inflammation in their lower respiratory tract, but they don't have any symptoms because the airway smooth muscle doesn't contract. So there's a researcher here, Dr. Jerry Cox, who's very involved in a line of research where they put a tube, a bronchoscope, down into the airway. They stick a little heating coil out from the end of that tube, and they heat it up. When you do that, the airway smooth muscle atrophies and disappears. So if you can get into enough airways, you can get rid of the airway smooth muscle. The problem with this approach is it's very difficult to get down into all of those 23 generations of airway. You're limited to the ones you can reach. But when he's done that, what Dr. Cox has found is that getting rid of airway smooth muscle improves the control of the asthmatic. So if we can find a way to get rid of all the smooth muscle, we think we can cure asthma. We won't cure the inflammation, but we think we can prevent Jamie from having any symptoms. Other interventions are going to require finding a way very early on, possibly, to prevent this allergic inflammation, stopping the structural changes. But I think Paul's point that if we can get patients to manage their asthma very well by taking the right drugs at the right time, we can still reduce symptoms. So I'm going to stop right there and opening up to questions that hopefully Dr. Byrne, I, or even Jamie can help you with. Thank you.